Hello everyone, I am Vijay Kumar BU. I will explain Men's syndrome. Introduction. Men's syndrome is a hereditary cancer syndromes, neoplastic transformation in multiple target endocrine tissues like parathyroid, pituitary, pathologic involvement of non-endocrine tissues like angiofibromas and neuroma. There are three types of Men's syndromes: Men's syndrome 1, 2 and mixed syndromes. First, Men's syndrome 1. This includes parathyroid hyperplasia, adenoma, isolated cell hyperplasia, adenoma or carcinoma, pituitary hyperplasia or adenoma. Other less common manifestations are foregut carcinoid, pheochromocytoma, subcutaneous or visceral lipomas. Men's syndrome 2. There are two types again: Men's syndrome 2A, Men's syndrome 2B. Men's syndrome 2A includes MTC, pheochromocytoma, parathyroid adenoma. Men's syndrome 2A with cutaneous lichen amyloidosis. Men's syndrome 2A with Hirschsprung disease. Men's syndrome 2B includes MTC, pheochromocytoma, mucosal and gastrointestinal neuromas and morphonoid features. MTC means medullary thyroid carcinoma. Third one is mixed syndromes. Van Hippel-Lindau syndrome. It also includes pheochromocytoma, isolated cell tumor, renal cell carcinoma, hemangioblastoma of central nervous system, retinal angiomas, neurofibromatosis with feature of MEN1 or 2, Carney complex, myxomas of heart, skin and breast, spotty cutaneous pigmentation also present in mixed syndromes. Men's syndrome type 1, Wermer syndrome, it is also called. It is inherited as an autosomal dominant trait, generally manifest by third or fourth decade. Although rare, Men's syndrome 1 is the most common Men's syndrome with prevalence of 2 to 20% per lakh. Men's syndrome 1. Men's syndrome 1 tumor suppressor gene whose mutations are responsible for Men's syndrome 1 chromosome 11q13. It codes for menin. Menin is ubiquitously expressed in endocrine and non-endocrine tissues. Men's syndrome 1 clinical features are: clinically, Men's syndrome 1 defined as occurrence of neoplasms in at least two target endocrine tissues like parathyroid, endocrine pancreas and pituitary. Familial Men's syndrome 1 defined as additional occurrence of at least one tumor type in a first degree relatives. Men's syndrome 1 trait almost 100% penetrance but with variable expansivity, so that each affected person may exhibit some but not necessarily all component of syndrome. Men's syndrome 1 parathyroids. Most common, greater than 98%. Typically enlargement of parathyroid MEN1 type patients is asymmetrically at any point in intervention. Hypercalcemia, that is asymptomatic for long time, may precede the clinical onset of pancreatic NET pituitary neoplasma. Renal lithiasis and skeletal complication occur uncommonly. In familial Men's syndrome 1, hypercalcemia is milder than sporadic. Men's syndrome 1, it shows X-ray of Men's syndrome 1 parathyroids, subperiosteal bone resorption. Men's syndrome 1 parathyroids. Diagnosis includes increased serum calcium level with an appropriately elevated parathyroid hormone level establishes the diagnosis. Typically, we have markedly elevated 24-hour urine calcium excretion. When prospective biochemical screening, the onset of hypercalcemia as early as 11 to 14 years of age. Men's syndrome 1, it also affects pancreas and duodenum. 30 to 80% of patients with Men's syndrome 1 develop NET, second most common manifestation of Men's syndrome 1, typically multifocal and diffuse isolated cell hyperplasia, and microadenomas. Gastrinomas frequently occur within the wall of duodenum or in extrapancreatic sites. Significant malignant potential and result in most of the Men's syndrome 1 disease related morbidity and mortality. Men's syndrome 1 gastrinomas, usually malignant, approximately 80%, previously believed to be located predominantly in the end of pancreas within the gastrinoma triangle, within the wall of duodenum. Zollinger-Ellison syndrome, that is ZEST syndrome, manifests symptoms like epigastric pain, reflux esophagitis, secretory diarrhea, and weight loss. Gastrinomas. Diagnosis includes documentation of gastric acid hypersecretion greater than 15 milliequivalent per liter and elevated fasting levels of serum gastrin greater than 100 picogram per ml. confirmed by an abnormal secretin test. Treatment includes localized resection of potentially malignant NET is indicated, extensive regional lymphadenectomy, unresectable gastrinoma or extensive metastatic disease, medical management with PPI, parathyroidectomy because normalization of serum calcium less improves thus. Men's syndrome 1 also affects pituitary. The most frequent pituitary tumor of Men's syndrome 1 is prolactinoma. Symptoms are due to hypersecretions of hormones or a compression of adjacent structures. Large adenomas affects visual disturbances and hypopituitarism. Prolactinomas cause amenorrhea and galacturia in women, hypogonadism in men. Acromegaly is growth hormone secreting tumor. Cushing syndrome, that is disease, adrenocortical thyroid hormone secreting tumor. Then comes Men's syndrome 2. Men's syndrome 2 includes Men's syndrome 2A and 2B and medullary thyroid carcinoma, that is FMTC. Hallmark is MTC. Men's syndrome 2A is MTC, pheochromocytoma, parathyroid hyperplasia and adenomas are included in Men's syndrome 2A. Men's syndrome 2B includes MTC, pheochromocytoma, mucosal and gastrointestinal neuromas and morphonoid features. Pathology and genetics includes RET, rearranged during transfection chromosome 10. Proto-oncogene encodes a receptor tyrosine kinase protein involved in growth, differentiation and migration of development of tissues. Specific mutations in RET decide the phenotype. Mutations in extracellular cysteine codons of RET, Men's syndrome 2A. Mutation in tyrosine kinase domain of RET cause Men's syndrome 2B. Mutations in extracellular or intracellular cysteine codons of RET cause FMTC. Men's syndrome 2A, also called as Sippel syndrome, MTC, that is penetrance is almost 100%. 40 to 50% will develop pheochromocytoma. The degree of penetrance of pheochromocytoma is Men's syndrome 2A correlates with specific RET mutations with the highest expression in carriers of mutation at codon 634. Hyperparathyroidism in 20 to 35%. Men's syndrome 2A, cutaneous lichen amyloidosis, amyloid deposition in papillary dermis, pruritic cutaneous plaques, interscapular regions are extensor surfaces of extremities. Hirschsprung disease has been associated with Men's syndrome 2A. Men's syndrome 2B, MTC in Men's syndrome 2B, a very young age in infancy, most aggressive form of hereditary MTC. All Men's syndrome 2B individuals have mucosal neuromas. 40 to 50% of patients develop pheochromocytomas. Distinct physical appearance with a predominant mid-upper lip, everted eyebrows, multiple tongue nodules and morphonoid habitus. Ganglion neuromas of intestine in submucosal and myenteric plexus. Men's syndrome 2B shows these pictures. Men's syndrome 2B. Men's syndrome 2B. All PTs have megacolon and usually have chronic bowel problems. Intestinal dysfunction may manifest early in life with poor feeding, failure to thrive, constipation, or pseudo-obstruction. Adults with this disorder may have dysphagia from esophageal dysmotility. Screening and genetic testing. Past pentagastrin stimulated calcitonin testing. Now standard screening test for Men's syndrome 2, sequencing of RET gene to detect germline mutations if possible. Testing should occur at birth, clinical screening and preventive surgery. When an MTC patient with no known family history of MTC or Men's syndrome 2 is found to have RET mutation, that is index case, all first degree family members should be offered genetic counseling and testing. RET mutation testing is also indicated for adult or pediatric patients who present with MTC or pheochromocytoma. 24% of pheochromocytomas are hereditary with 5%. MCT. 25% occur within spectrum of MEN syndrome. Patients with familial syndrome present at a younger age group. Multicentric familial MTC cases. Bilateral 90% familial syndrome cases seen. MCT clinical features include neck mass. 50 to 20% may have cervical lymphadenopathy. Pain or aching is more common in these tumors when compared to other tumors. Local infiltration includes dysphonia, dysphagia, dyspnea. Distance mets liver, bone, osteoblastic, that is lung appear in later stages. MCT diagnosis includes most commonly IHC for calcitonin is used as diagnostic marker. Presence of amyloid is also diagnostic. Also stain positively for CEA and calcitonin gene related peptide. FNA cytology of thyroid mass. Should be screened for RET point mutations, pheochromocytoma and HPT. MCT management includes a neck ultrasound is recommended to evaluate central and lateral neck compartments and superior mediastinum. Calcitonin levels greater than 400 picogram per ml. Additional imaging includes neck and chest CT and triple face liver CT and contrast enhanced MRI with recommended to assess for metastatic disease. Pheochromocytoma. Neoplasma arising from chromaffin cells in adrenal medulla, that is catecholamines. 40% to 50% of patients with MEN syndrome 2A and 2B. Age at DX 30 to 40 years associated with MEN syndrome 2 are always benign and confined to adrenal medulla. Multifocal and bilateral, greater than 50% of cases seen in pheochromocytoma. Pheochromocytoma, this pic shows pheochromocytoma clinical features. Clinical features include symptoms of catecholamine excess, headache, hypertension, palpitation, tremors, and anxiety. Unregulated catecholamine devastating consequences, stroke, myocardial infarction, and sudden death. Pheochromocytoma. This pic shows CT scan of pheochromocytoma. Pheochromocytoma treatment includes in past recommended bilateral adrenalectomies for all MEN syndrome 2 patients, significant risk of adrenal insufficiency and Addisonian crisis. Pheochromocytomas are not malignant in MEN syndrome 2 patients, and the interval between the development of pheochromocytoma on one side and the other side is more than 10 years. Now recommended removing only affected adrenal in setting of unilateral pheochromocytoma in MEN 2 patients with annual screening. LAP is preferred if tumor is less than 9 to 10 centimeter. MCQs includes first one, MEN syndrome type 1 syndrome is inherited as which of the following trait? Option A, autosomal dominant. Option B, allosomal dominant. Option C, autosomal recessive. Option D, allosomal recessive. Answer is A, autosomal dominant. Second question comes, the most frequent pituitary tumor of MEN syndrome 1 is option A, Cushing syndrome. Option B, acromegaly. Option C, prolactinoma. Option D, thyroid adenoma. Answer is C, prolactinoma. Third question is Sippel's syndrome, also known as option A, MEN syndrome 2B, mixed syndrome, MEN syndrome 1 and MEN syndrome 2A. Answer is D, MEN syndrome 2A. Thank you.